All right, party people. Today, we're going to be doing a little compare and contrast as to how to know when the USMLE is presenting us with multiple myeloma as compared to when they are presenting us with a patient suffering from metastatic malignancy. Now, in the case where they give you a patient with back pain and normal serum biochemistry, as well as a normal protein electrophoresis, however, seeing lytic lesions in the spine, we know that this is metastatic malignancy. Lytic lesions are characteristic of METs. Now, the mechanism by which metastatic cancer can spread and create lytic lesions is via localized cytokine activity, particularly interleukin-1, that's also known as aka osteoclast activating factor. This concept is very high yield for the USMLE. Increased cytokine activity promotes osteoclast-mediated bone resorption. IL-1 and IL-6 activity increases rank L expression, promoting osteoclastogenesis. Estrogen normally suppresses this activity, which is relevant in postmenopausal osteoporosis. Now, the reason this is not multiple myeloma is because this patient had normal serum protein electrophoresis. Normally, in multiple myeloma, you'd expect a monoclonal M protein spike, typically IgG or IgA light chains. After a positive serum protein electrophoresis, we would follow this up with a bone marrow biopsy. Other things that would point to multiple myeloma would be Bence-Jones proteins in the urine, elevated ESR. This is due to rouleau formations, basically sticky RBCs caused by excess immunoglobulins stacked up like coins. Hypercalcemia, although metastatic disease can also cause this. You would see this also in metastatic disease. Some other distractors that they might hit you with: avascular necrosis. Now, this commonly appears in 5 situations. So the first would be idiopathic AVN. This is in pediatrics. Idiopathic AVN in pediatrics is known as leg-calf-Perthes disease. This typically presents as a painful limp in children, aged 5 to 10. Another way you can have AVN is sickle cell disease. Avascular necrosis of the femoral head is a known complication of sickle cell. Gaucher disease, spelled Gaucher disease, is a lysosomal storage disorder caused by glucocerebrosidase deficiency, leading to a glucocerebroside accumulation, which can also cause avascular necrosis. Another possible cause of avascular necrosis would be Cushing's syndrome or chronic steroid use. So, exogenous corticosteroids such as prednisone are a very common cause of AVNs in adults. Another classic example of USMLE avascular necrosis is scaphoid fractures. This is following a fall on an outstretched arm. You have pain in the anatomical snuff box and a negative initial x-ray. Normally, we treat this with a thumb spica cast and a repeat x-ray in 2 to 3 weeks. Another possible distractor would be osteoporosis. Now, in this case, osteoporosis does not produce lytic lesions. It typically presents with diffuse decreased bone density and no focal deficits. Lab values are normal. This is important. So that means calcium, phosphate, ALP, etc. are all normal. Lytic lesions are more specific for metastatic disease and multiple myeloma. Those are the 2 primary indicators. When you see lytic lesions, you want to be thinking either METs or multiple myeloma. Now, renal osteodystrophy is another one that they might hit you with to distract you, and this implies bone problems secondary to chronic kidney disease, often due to impaired conversion of 25 vitamin D to 125 vitamin D, resulting in osteomalacia. This is a vitamin D deficiency pattern. Clues that would suggest this, but are absent here, would be chronic kidney disease followed by elevated bun creatinine ratio, dialysis, as well as lab or abnormalities. You would see low calcium, high phosphate. Know that the USMLE often equates renal osteodystrophy with osteomalacia and may use the term pseudofractures as a clue. These are specific to vitamin D deficiency. So when you see pseudofracture, I want you thinking vitamin D deficiency. So just to wrap it up, for metastatic malignancy, you're going to see lytic lesions in the spine, normal serum protein electrophoresis. This in itself rules out multiple myeloma, and no findings suggested of avascular necrosis, osteoporosis, or renal osteodystrophy. That's it for this one. Go crush it.